Okay, so like I said, antiretroviral therapy, this is meant to be very clinically based, very case-based, of very practical cases, things that you guys might see, and sort of each case has a goal of trying to emphasize key points that you guys need to know in the management of antiretroviral therapy. Okay, and this comes from ID board review that some of you will be going to pretty soon. The ID boards are 15% HIV, basically. A lot of that is treatment regimen, some of it's opportunistic infections, and then miscellaneous other things related to prevention, other stuff. This slide shows, are also from ID board review, they show on the left is all the approved antiretroviral therapy agents we have as of last year. And on the right are the approved single tab regimens. As most of you know, for most people with HIV, our goal is to get them to a single tab, one pill once daily regimen. It improves adherence, which improves viral suppression. It looks like a whole lot. I would say when you look at the one on the left of all the individual agents that are approved, there's a lot of them we don't really use so much these days. There are rare cases where we use some of them. I whited out, but these are more the ones that you're going to see. And we really, most patients don't use some of these other classes. And so the ones that are left are the most important ones for you to start with. Over time, you should learn all of them. But if you need a starting point, this gives a more manageable starting point. Just as an overview to antiretroviral therapy, I know you guys had the test and treat lecture and have had other introductions. Our single tab regimens, or all of our regimens, are generally either 2 or 3 drugs. And it's often 1 or 2 NRTIs plus something from another class, though our 2-drug regimen sometimes mix that up. A really important point, and something you'll see over and over, is that some of our drugs are used all the time. Integrase inhibitors, especially Biktarvy and dolutegravir in particular, and then our protease inhibitor, which the only one we really use these days is darunavir. These 3 drugs have a high barrier to resistance. That means it's harder for the virus to mutate and develop resistance to these. And for that reason, we generally prefer them over other agents. Other agents work as well, but these are the ones that you're going to see just over and over. And our goal of antiretroviral therapy is always virologic suppression. These are a couple key resources I use. The HIV clinical info is the official guidelines. I use it when I'm looking up a specific piece of information. I find it a little like unwieldy to just like flip through casually. The National HIV curriculum is awesome. It's readable. It has question banks. It has a short version and a long detailed version. It's like the go-to source. So if you're listening to this lecture and you feel like you're just like, what is she talking about? This is like another language. I don't know any of this. I would recommend you go here and start. You can go to this course modules or the medications. You can find somewhere to start and to look through. And then they have questions, which many of the questions in this one are taken from this question bank or adapted from it. Okay, so quick review, what's in common single pill regimens? So I'm going to ask our second year fellows who are on the call to answer some of these. So we're just going to do flashcards basically. So Biktarvy, what medications are in it?
Bictegravir, FTC, TAF.
And what's FTC?
And Procitibine.
Emtricitabine, yeah. Good job. Okay, so we've got 1 integrase inhibitor and 2 NRTIs. What about Simtuza?
That one is elvitegravir, cobicistat, darunavir, and
I think you're combining Genvoya.
Or am I thinking? No, I'm thinking Genvoya. Never mind.
Yeah, you're getting there with Simtuza. The last one you mentioned was on track.
Oh gosh. Never mind. I'm blanking. Sorry, I'm in a staircase.
Oh, there was a weird echo. That makes sense. Okay. Yeah. So Simtuza is pretty much our main 1 pill once a day regimen we use that has a protease inhibitor in it. So it has darunavir along with cobicistat. Cobicistat is a booster to get darunavir to appropriate levels. It's not an effective agent on its own. And then we have TAF and emtricitabine. Those were in Biktarvy as well. Jaluka.
Dolutegravir and molnupiravir.
Good. Yeah, this is one of our two drug regimens. So dolutegravir is an INSTI integrase inhibitor, and then rilpivirine is an NNRTI. Triumec, anyone remember this one?
Is that abacavir, dolutegravir, lamivudine?
Yeah. So dolutegravir is our integrase, and then abacavir and lamivudine are NRTI pair. So this one's a little different. Most of our other ones have tenofovir in them, and this one doesn't. What about Dovato?
Dolutegravir, lamivudine.
Yeah, exactly. This is another 2-drug regimen, and it only has one NRTI and one INSTI. It's another approved regimen. And last one, Cabenuva, is our long-acting injectable medication. What's in this one?
Cabotegravir, rilpivirine.
Yeah, cabotegravir, rilpivirine. Perfect. So it's a lot like it has an integrase inhibitor and an NNRTI. That's what Juluca has, dolutegravir and rilpivirine. It's a pill that's very similar to Cabenuva. Okay. That was just a quick run through because you guys are going to see these names, and in clinic, especially early on in the year, if you're presenting to me, I'm probably going to ask you what's in the medication when you present. So just be prepared. So we're going to start with ART initiation cases. Lauren, can you read this one?
Yes. 28-year-old male. Sorry, I think there might be some echo.
That's fine. I'll ask Silly, are you on? Can you read it?
Are you able to hear me?
Yep.
Okay. 28-year-old man is newly diagnosed with HIV and starting ART labs with HIV antigen antibody screen reactive, HIV-1 antibody reactive, HIV viral load 1.5 million, Hep B core antibody non-reactive, Hep B surface antibody non-reactive, Hep B surface antigen non-reactive, creatinine is 1, and CD4 is 350. Which of the following are recommended first-line treatment options appropriate for the patient? Select all that apply.
E and A.
Yeah, so before we go to the answer, we had done this last time. Since we just flipped through them, I'm not going to make you guys tell me them. But in case anyone was curious, these are them. I'll give you a second just to look at them. And then Kirtan, did I have...
What was the viral load again?
The viral load was 1.5 million. Why do you ask?
Because he needs to be less than 500,000 for like the Dovato, Juluca.
Yeah, the 2-drug regimens can't take us such a high viral load.
Yeah. So which ones? I think Kirtan, I heard you saying the answer earlier, but what
I
was
said
your
A.
guys? Okay. Anyone have a difference of opinion they'd like to air? Okay. Yeah. So A&E, and we're going to show you a chart with the first-line treatment options for ART initiation. In terms of this, we see that the middle option, dolutegravir lamivudine, is in the guidelines as a initial regimen you can do in someone who's treatment naive, but only if the viral load is less than 5,000. Since it's greater than 500,000. Since it's greater than 500,000 for this patient, he would not be a candidate for that. B and D are not recommended first-line regimens. So this is something, if you have a brand new patient, I know you guys talked about test and treat last week. These are the recommended regimens for ART initiation, and the comments give you caveats. So most of them are integrase, they're all integrase inhibitor based with either 1 or 2 NRTIs. The one with dolutegravir, abacavir, lamivudine, we can only use abacavir if we know HLA-B 5701 is negative. Otherwise, you have a risk of a hypersensitivity reaction. This regimen we'll also get into later doesn't cover for hepatitis B infection effectively, so we wouldn't want to use it if someone had that. And in this case, you had his labs showing that he was Hep B negative, non-immune. The 2-drug regimen, dolutegravir, lamivudine, we already talked about. In practice, I find this one hard to start in a test and treat type of situation because if you're just, if you're seeing someone and their HIV test is positive and you want to get them started on treatment that day and they want to be on treatment, you're probably not going to have much of this information that you need to have in order to use this regimen. So in effect, most people honestly end up on Biktarvy. a lot of people. But these are the other options you could consider. And the reason is sort of we've already hinted at. We prefer integrase inhibitors over PIs or NNRTIs as our anchor drug. They're very effective. Bictegravir and dolutegravir have a high barrier to resistance, and they're generally very well tolerated and have minimal drug interactions. But if you do have a patient with a specific scenario, you can pull up the guidelines and look at alternative recommendations that are acceptable regimens too. Okay, so case 2. John, are you able to read it?
Yeah. A 37-year-old male presents for general malaise for about a week, is found to have acute HIV with a viral load over 10 million.
Oh, yeah. So there's more.
He was previously on, yeah, no worries. He was previously on PrEP for HIV prevention, receiving injectable CAB. His most recent injection 3 months prior to current presentation, HIV test negative at that time. He would like to start ART today. Which of the following regimens is most appropriate to start?
So how is this case different from the last one? In both cases, you have someone with a new infection ready to start antiretroviral therapy today.
He was previously on PrEP.
Yeah. And how does that change what regimen you would start with?
You would try to avoid integrase inhibitor.
Yeah. And so I'm not going to make you guys spell it out, but the only option here that does not include an integrase inhibitor is option B, darunavir, ritonavir, taf, emtricitabine. And people who have been on, so cabotegravir, this isn't a PrEP talk, I'm not going to go on it for too long, but long-acting CAB can stay in the system for like up to a year or so after an injection. And so if people have recently received cabotegravir for PrEP, and now they have an HIV infection, you worry that the virus they have has now been exposed to subtherapeutic levels of cabotegravir for some period of time. So you worry that they could have resistance to integrase inhibitors. And it has been reported in trials that people in the cabotegravir arms of trials for PrEP who get HIV, there is resistance that has occurred. So in this situation, you would avoid an integrase-based regimen up front until you have a genotype, because not everyone gets resistant. So the top part of this graph is from our case number 1. Those are just the standard what to start. What's your first line regimen for antiretroviral therapy? At the bottom, the guidelines now have this caveat that if you had prior long-acting cabotegravir use for PrEP, then you should do a genotype, but if you're starting ART before you have the genotype back, start this darunavir-based regimen. And this is new since cabotegravir, for anyone who hasn't been in the HIV prevention world for long, cabotegravir is really new in the past couple of years for use as PrEP. And this basically says the same thing, that you always get a genotype when people come in, but if people are new HIV diagnosis, you just get a standard genotype, which our standard genotype orders often don't include integrase inhibitors. If you were to have prior cabotegravir exposure, you'd want to get a genotype, but you want to make sure you get standard and integrase, not just the standard genotype alone. Okay. Who else? Celia, are you on and able to read this one?
Yes. A 43-year-old man was diagnosed with HIV 8 years ago with a CD4 count of 956 and viral load under 200. He was told he is an elite controller and does not need to take ART. His viral load has remained suppressed over the past 8 years. Today, you see him for routine follow-up and note the following trend. His CD4 count went from 956 to 882 to 642 to 332 over the last 8 years. What is the next step in management? Start ART, I would say.
And why?
I forgot the actual criteria of the CD4 count, but in general, you're seeing a CD4 count drop, so you might have some low level viremia contributing to this. So his CD4 count dropping, especially closer to 300, be safer to start ART in this gentleman.
Yeah. Have any of you guys actually had an elite controller patient?
Yeah,
Not I.
I have two.
Once.
You have two. Do you have them on ART?
Oh, I have one guy on ART.
Yeah, mine too, but he's like a not adherent patient. He just always happens to never have like viremia or a low CD4 count. So he's supposed to be on ART, but he's just not.
I might have seen a note, been reviewing his chart in health department the other day for something, if it was that one. Okay. And you guys are right. And the trend is in that drop in CD4 count is really the key here that you recommended. For people who are elite controllers, and we'll define that on the next slide, the management isn't super well defined. Generally, you definitely start ART if there are signs of disease progression, like if their CD4 counts dropping, like this one, which is a consistent trend. I will say with CD4 drops, if you know, oh, this one says CD5, that's an error. It's not a thing. If a CD4 count drops on one single lab and they're like, say, and it's a person who's taking ART, they're virally suppressed, I don't make too much of it. We know that, you know, acute illness, a cold, a virus, whatever's going on could drop the CD4 count once. So we really look at that overall trend more so. And this patient clearly had an overall declining trend. Guidelines will say if we don't see signs of HIV progression, the benefit of ART is less clear, but we do know that people who are elite controllers, not on ART, there is inflammation that can be detected, and that inflammation from having this chronic low-level virus may impact cardiovascular, non-HIV AIDS associated morbidity and mortality. So I think most people would aim towards starting, but it's really a discussion. And if you don't start ART, you don't want them to just not follow up with HIV clinic. They should still follow up over time. There are technically two different words. There's elite controllers and viremic controllers. Elite controllers are on the left of this. Elite controllers, as you can see, without antiretroviral therapy, are able to maintain their viral load below 50, below whatever your limit of detection is. So they're undetectable. And usually their CD4 count's staying high. There's also viremic controllers who have a low but detectable viral load. And so these people, because that viral level is low but detectable, they are more likely to see a decrease in CD4 count over time. These figures are from the National HIV curriculum that I use all the time. Okay, so let's now move into... Yeah.
Do you mind if I say just a couple of additional words about elite controllers?
Yeah, do it.
This is Zach Porterfield. Yeah, so this was part of my study when we were at Yale, actually, was on elite controllers. And another term that you guys may come across is long-term non-progressors. And what's interesting is that in 40 years of research, we don't really understand why people are elite controllers. You know, is this a viral fitness thing? Is this an HLA type thing? And it probably is an overlap of a bunch of different mechanisms. Bob Gallo, who recently was hired, the discoverer of HIV, he's convinced that this is just sort of a low initial dose of virus that gets suppressed and that you just never have establishment of a large reservoir. But it's quite a mystery. And interestingly, it's now going to be harder and harder and harder to study elite controllers because everybody gets started on antiretrovirals immediately. And so you would never take someone off antiretrovirals to see if they were elite controllers. And so the cohorts that we have were mostly discovered when we would wait for CD4 counts to drop, before initiating antiretrovirals. But just sort of an interesting subsection of HIV research is that elite controllers are going to be very difficult to identify moving forward. And it's probably going to be quite rare in our career that we will start somebody who is known elite controller on antiretrovirals for the first time.
Yeah, thank you for that. And a really interesting point about we might not even know about them. We do have, maybe that was the note I actually saw. One of our fellows in clinic had someone who had been off what was still undetectable, and they had clearly been off for months, and it was like question mark elite controller. But like you said, prior to that, they were always on ART, and so no way to recognize it.
Thank you.
Yeah, thank you. Okay, so those were all questions about sort of starting ART. Let's move into now what we see much more commonly, which is people who are already on antiretroviral therapy and then things that come up. So case 4, Kirtan, are you able to read this one?
Yeah, I got this. 52-year-old cisgender woman with HIV was virally suppressed on efavirenz, tenofovir, DF, and emtricitabine for about 10 years.
10 years, yes, thank you.
She recently switched to bictegravir, tenofovir, alafenamide, and emtricitabine. She remains virally suppressed but has gained 11 pounds in the past 14 months. She denies major changes in dietary habits or activity level. Which one of the following statements is true about integrase strand transfer inhibitors, or INSTIs, and weight gain? A, none of the INSTIs have been associated with weight gain. B, weight gain with dolutegravir is more likely if combined with tenofovir, alafenamide, than if combined with tenofovir, disoproxil. INSTIs lead to less weight gain than protease inhibitors or non-nucleoside reverse transcriptase inhibitors. Among the INSTIs, albutegravir is most likely to cause weight gain.
D.
Okay, we got one vote for D. Anyone have other thoughts? Yeah. Have you guys
weight gain with the TAF and dolutegravir is more common.
Yeah, that is the correct answer. And weight gain and integrase, integrase, like we said, are the backbone of most of our go-to regimens these days. They're super effective, generally well tolerated, but with so many people on them, some people will have side effects, even if small. And there's a couple reasons that we've noticed that there is a trend for weight gain in people on our integrase-based regimens. The first one is that older ART regimens, things like efavirenz or TDF, the old tenofovir version, those can suppress weight gain. So if you're switching someone from a regimen with those to a regimen like Biktarvy with an integrase, you're going to have both, there may be some weight gain from your new regimen, but there also may be some weight gain because you're taking them off a regimen that suppressed weight gain. And then the reason integrase inhibitors are associated with a weight gain, the mechanism isn't really clear. It's been most noted for dolutegravir, though limited data in the studies I'll show you from bictegravir, which is thought to be similar. And the weight gain was more pronounced with TAF than TDF. And I think it's important to note that most people won't gain weight, and many who do, it will be a small amount, but for some people it will be more. And so on this top graph, you can see that dolutegravir in green, this is months after starting regimen and the change in weight. So dolutegravir seemed to have the most weight gain when compared to these other lines, which are a protease inhibitor regimen, raltegravir, NNRTI, and elvitegravir. In this study, elvitegravir actually didn't have any overall weight gain after 18 months. And then this study looked at different regimens and they separate out by men and women. We do see the weight gain is more pronounced in women generally. And so the dark green line is dolutegravir, TAF, emtricitabine, compared to this one, which is dolutegravir. The light green is dolutegravir, TDF. The brown bar is efavirenz, I believe, with a TDF, a standard group. So the weight gain is real if your patients report it. It does seem to mostly level off for people, but if you do have someone where it's becoming a real concern, it's something to think about. And unclear if changing will necessarily lead to weight loss. That's a question that comes up. Probably what generally the guidelines and the National HIV curriculum and other things are like, you should counsel patients when you start about other lifestyle measures, like healthy diet and exercise, so that they are less impacted by the weight gain. I'm sure we will learn more about that over coming years. Okay. Case 5. I think I ran through our second year fellows who I saw on the call, unless Becky is here hiding. So first years, I can't see who's on the call. Could someone volunteer to read this?
I could read it, Dr. Sherbuk.
Sure.
Yeah, I can read. Here we go. 70-year-old cisgender man with HIV and hypertension presented to a clinic to discuss a potential update to his antiretroviral therapy. He has been taking tenofovir, DF, emtricitabine daily, plus raltegravir, BID for 7 years with a routinely undetectable HIV RNA level, but reports intermittently forgetting the second daily dose of raltegravir. In the past year, his serum creat has been slowly rising, with an estimated GFR of 50 mils per min and 1+ proteinuria. Prior HLA-B5701 test was positive. you are considering switching to the single tablet regimen, bictegravir, tenofovir, alafenamide, and tracidabine. Which one of the following would be expected with the switch of tenofovir DF to tenofovir alafenamide?
Before we get to this, I really use this case to illustrate, there's two different versions of tenofovir. There's tenofovir difumarate, I'm blanking on the name, but DF, TDF, and then there's TAF, tenofovir alafenamide. And what were the reasons that we have switched many patients? What are the side effects of TDF that you guys know about?
Osteoporosis.
Mm-hmm.
So,
And renal dysfunction.
Yep. And renal dysfunction. Yeah, those are two of the really big ones. Does anyone have an idea on which of these parameters would improve if you switched?
I think B. I don't.
Yeah, that would sort of go in line with what we just said, right? So I want to make sure you guys know the difference between TDF and TAF. So if you look at this graphic, again, from the national curriculum, so both TDF and TAF you swallow, right? They go into the bloodstream, and you can see by the thickness of the arrows how much goes into each place. With TDF, you get a lot of the active form of tenofovir you get a lot of tenofovir in the bloodstream. If you look at the TAF, only a small amount is in the bloodstream, and most of it goes straight into the cells, where both are converted into the active metabolite. It's thought that the fact that TDF is more extracellular, where TAF is more intracellular, that may play a role on some of these adverse effects we see and why we see more with TDF. So the main things we've worried about with TDF are what you guys said, osteoporosis from bone demineralization, and then the nephrotoxicity. It's mostly proximal tubule dysfunction. So we monitor UAs and electrolytes and renal function over time in people who are on TDF, though there's fewer of those these days. So we switched to TAF. If you see in that top right box, when you switch, you can get improved bone mineral density and some improvement in proximal tubule dysfunction. But TAF is not, without its issues that come up. And so adverse effects associated with TAF are more metabolic. We can see an increase in total cholesterol and HDL. And we already talked about that weight gain when TAF is used in combination with dolutegravir. In general, based on the effect profile, we generally prefer TAF in our patients. And you'll see that most of the newer regimens are TAF based rather than TDF. Case 6, could someone read that one?
I can.
Thank you.
Let me read on Kurt. Sorry. Okay. We've got a 39-year-old cisgender woman with HIV, presents to the emergency room with a diffuse erythematous rash. She restarted on ART 2 weeks ago with a regimen consisting of darunavir, cobicistat, tenofovir, alafenamide, emtricitabine, doravirine, and fostemsavir. She has prior history of developing diffuse erythematous rash when taking trimethoprim sulfa. She has no other symptoms and is afebrile. Additional lab studies show normal hepatic aminotransferase levels and no evidence of eosinophilia. Which one of the following is most likely cause of the patient's rash? Okay.
Anyone have a thought on this one?
I'm wondering too with the Bactrim and the protease inhibitor.
And what's the connection?
We were
there?
thinking that it may impact drug levels with interactions. I don't know.
She's not actually on Bactrim. She just had a rash with Bactrim in the past.
Oh, I'm sorry. Okay, then there may be some cross-reactivity there.
Yeah. Okay. Do you know which one of these agents has a sulfa moiety on it?
You want to go with A? Okay, we'll go with A.
Okay, the TGH Echo team goes with A. And you guys are correct. And you guys, whoa, sorry, Lauren, I think you're still echoing. There's basically any antiretroviral can be associated with a rash, generally mild. But if you look up on the guidelines, sort of like adverse effects after ART initiation, rash, they often talk about it when people are on NNRTIs or on darunavir. And for both of them, they say it's mild. Usually you don't have to switch. You can just continue treatment, but you want to be aware of any signs of a more severe rash, right? And this gives you options of what to switch to, which generally you would not be switching to this. You would just be switching to a new class, but this is straight from the guidelines. And darunavir has a sulfa moiety, so people with a history of a sulfa allergy may have an increased risk of a rash with darunavir. And we know that sulfa allergies are relatively common in people with HIV. So this is something that could come up. If someone does have a sulfa allergy, it doesn't mean you can't start darunavir, but maybe if they had like SJS, you could consider avoiding, is what I was reading. But again, many people, like they say 10% of people you start on darunavir may develop a mild rash, but most people will continue taking it. And if rash is severe, then you stop. I think we definitely see this in clinics sometimes, though sometimes by the time we see them, the rash has even resolved. Or, there's always the question, whenever someone comes in with a rash, it's always often, especially if it's over the phone, really hard to pinpoint what exactly it's from. But most people get better. So that's great. So in next case, we're going to talk about antiretroviral therapy in people with certain other conditions. So in this case, hepatitis B. Could someone read this one?
Yeah, I can read it. So there's a 32-year-old transgender woman presenting for routine follow-up for gender-affirming care and management of HIV. She was diagnosed with HIV 4 years ago. Baseline labs showed positive HB surface antigen. She took elbapentagravir, cobicistat, TDF, emtricitabine for 3 years, and then 1 year ago switched to bictegravir, TAF, emtricitabine. She has persistently undetectable levels of HIV RNA and HBV DNA on this regimen, but cholesterol has become elevated over the past year. She's very concerned that TAF is playing a role in her elevated cholesterol and has requested a new regimen that does not include TAF. Which one of the following regimens should be recommended?
Does anyone have a thought on which of these dolutegravir-based regimens will be appropriate for her? What do you guys?
I'm going to go with C.
Okay. And why C?
Not sure, but I was trying to avoid the tenofovir specifically for hepatitis B. Like it could like partially treat it.
Oh, okay. Yeah, so tenofovir is definitely active against hepatitis B, and we want to make sure we're fully treating it. So we're going to talk about that on the next slide. Anyone else have thoughts on what Fernando has commented?
From what I remember, you can't use lamivudine alone, though it has some activity against Hep B, so you really need it with another agent if you're going to be using it. So the bacavir, I think, should be covering it. So C would be an option.
Okay, great. So this is a great question because you guys got it wrong. So let's go over why. So hepatitis B co-infection is pretty common in people with HIV. And our goal is that we want to treat both of them fully, right? So for HIV, we're always looking for 2 to 3 agents that are effective against HIV. And for hepatitis B, our goal is 2 active agents for Hep B. And so it's convenient that many of the agents we use to treat HIV also treat hepatitis B. So tenofovir in either form treats hepatitis B, and it's actually our favorite drug for the treatment of hepatitis B and HIV. Lamivudine and emtricitabine can both treat it as well. Of note, abacavir does not have activity against hepatitis B. But this third block here says to be wary. Either lamivudine or emtricitabine alone can lead to hepatitis B resistance, which is what Celia remembered, that key fact. And entecavir is another Hep B agent that we wouldn't recommend without like a full HIV regimen. We'll get to that little block next, or the last block next, but first I want to go to this graph. So, and this is the reason why we don't use lamivudine alone in people with hepatitis B. So once you've been on lamivudine alone by 24 months, about half of people, so in 2 years, have resistance to lamivudine from their hepatitis B, not their HIV. And then if you go out to 4 years, it's like 90, I can't tell what this is, 95% of people who are resistant to lamivudine if they were only on lamivudine for their hepatitis B treatment. So we really try to avoid single monotherapy with lamivudine or emtricitabine, which is very similar to lamivudine, because of the risk, the very real risk of hepatitis B resistance. So in most cases, we're going to be using tenofovir plus either lamivudine or emtricitabine, which is why, going back to this question, D was the correct answer. So you guys were getting there. You were trying to find the agents that had Hep B activity and trying to find 2 of them. And so it's tenofovir and emtricitabine is fine. The last bullet point here is something just to make people aware of, that we never want our patients with HIV just stopping their therapy for any reason generally. But if they also have hepatitis B, if they do abruptly stop their treatment, they can have a flare, which means they can have like liver inflammation, their LFTs can go up, and it can, in very rare cases, develop into more of a fulminant picture. You treat that by just restarting the ART that's effective against both HIV and Hep B. You know that hepatitis B can be a really confusing topic. In our like mini lecture series in clinic, we'll talk more about hepatitis B and interpreting serologies and what to do about the weird situations that come up. But their Hep B status is one thing I'm always going to be asking you guys. If you guys are proposing switching someone's HIV regimen, I'm always going to be asking about this. And sometimes you have to dig through the records to find it. So keep that in mind. Okay. Next case. So this is antiretroviral therapy in someone with CKD.
I can read this one. So 23-year-old woman with perinatally acquired HIV and multi-drug resistance restarted ART after a year off ART. She's on salvage regimen of doravirine, dolutegravir, darunavir, ritonavir, and TAF entricitabine. On follow-up 1 month later, viral load is 1,000 from 1 million, and creatinine is 1.1 from 0.9, no proteinuria and UA. Which component of the ART regimen is most likely caused the rise in the creatinine?
Does anyone have a thought on which one of these agents can cause a rise in creatinine?
Or the dolutegravir?
That echo. Okay, we've got a vote for dolutegravir. Anything else? Okay. Good choice. So we have HIV can affect the kidneys in different ways. There's HIV-associated nephropathy that you can get from the virus alone, and then you can get impacts from the medications we use to treat HIV. So TDF, we already talked about, can cause renal dysfunction. It can cause the proximal tubule dysfunction. I think it's also interesting to know that a few of our regimens that we commonly use, or a few of our agents, can cause an increase in creatinine due to inhibition of tubular secretion. And so if you look at this graphic, you can see that they just block the transport of serum creatinine in the proximal tubule. So your serum creatinine goes up a little bit, but it's not actually a true change in your GFR. And bictegravir, dolutegravir, rilpivirine, and cobicistat can do that. Usually they cause a change in creatinine of about 0.1 to 0.2, and then it stabilizes, but it shouldn't continue to rise. Honestly, in clinical practice, I feel like, a rise of 0.1, you probably just don't know whether that's even just like lab error, small fluctuations day to day. But the key point is, even though these can do that, you shouldn't see an ongoing change over time. If you do see an ongoing change over time, you need to investigate other reasons. And this leads me into Our one big challenge in managing HIV is when people have chronic kidney disease. And as that creatinine clearance drops, some of our medications need to be adjusted. So I sort of summarize this table. Our pharmacists can tell me if I have any major errors on here. But the main agents that often need to be dose adjusted are the NRTIs. So our tenofivirs, lamivudine, entrectinib. You often start running into challenges with many of our one pill once a day regimens once you get into CKD, because you have to break up the components so you can dose adjust certain parts. Often we can still find a regimen together. We have some regimens that don't even involve NRTIs, but keeping track of a patient's renal function is really important in HIV clinic. Okay. And it gets even more complicated if you have someone with chronic kidney disease and HIV, as well as hepatitis B infection. I had some slides on that, but I decided to save that for a more advanced lecture because that gets really complicated. Okay. Case 9, we only have 10 cases, so we're coming up on the end here. Could someone read this one?
I can read this one.
Sure.
A 55-year-old man with extensive drug-resistant HIV attends a routine follow-up visit and notes weight gain, easy bruising, weakness in the legs, and changes in mood, anxiety, and agitation. 7 months ago, he was started on TAF, emtricitabine, doravirine, and dolutegravir, and darunavir or ritonavir. Meds are ART and atorvastatin, loratadine, fluticasone nasal spray. Labs, his viral loads are non-detectable, CD4 of 314 and a glucose of 168. On exam, his blood pressure is 168/96. He's got central adiposity and scattered bruising. Which of the following scenarios likely explains his presentation?
I'll give everyone a second to read the answer choices since they're long. Okay, does anyone have a thought?
B.
And why do you say B?
Sorry, I'm chewing. Give me 1 second.
Okay.
Sorry.
It's okay. It's a
Hence
lunch and
the
learn. I
term
guess that happens. Yeah.
lunch and learn. Lunch and learn. I'm glad that you guys are having lunch.
He was already on fluticasone prior to starting this new regimen. And then all I know is when we learned HIV clinic, the ritonavir and fluticasone can interact. And then he took Cushingoid like presentation. So he has with the central obesity, the hypertension, and then his symptoms consistent with Cushing's disease.
Yeah. Yep, you got it. And you basically explained it. And the real learning point from this case is that when patients are on a regimen with a booster, ritonavir or covisistat in particular, well, those are our boosters, they interact with a lot of different medications. And so steroids are one that I use in this example because they come up a lot. People get steroids for all sorts of things. And there can be an interaction even with steroids that are not systemic, like in this case, inhaled or intranasal fluticasone. Some steroids are safer. And then there's a lot of other medication classes that interact with ritonavir and covisistat. So you can see the list there. I won't read it. Oh, that's a random comment, but the main point is if patients have a med you're not super familiar with or a new medication added, you need to be checking interactions, especially if your patients are on these boosted regimens, because a lot of other people won't check. And, you know, we see this in terms of people on even like pretty complicated regimens for cardiac disease or chemotherapy, oncology disease. Often, you know, you want to keep up with your patients on what meds they're on so you can make sure they're safe. This was just a random side comment that dolutegravir can increase metformin levels, so you might want to use a lower dose. And then last case is just getting to injectable ART, which is newer. Could someone read this one?
A 32-year-old cisgender woman has been taking bictegravir, tenofovir, alafenamide, and trocytamine for about 2 years. 2 months after starting this regimen, she has had suppressed HIV RNA levels, and she has maintained suppressed HIV RNA levels since then. A baseline HIV drug resistance genotype showed an M184B mutation and no other mutations. In the past 3 months, she has developed some esophageal problems and is very interested in taking long-acting injectable cabotegravir and rilpivirine injections instead of daily pills. Which of the following statements is true regarding the use of long-acting injectable cabotegravir and rilpivirine?
Okay, so let's go through these one by one. So A, long-acting injectable Cabenuva should only be used if the creatinine clearance is greater than 60. Is that correct?
No.
No.
Correct. Yeah, these are not, don't have the renal dose adjustment. I think it says if it's below some creatinine clearance to monitor closely for side effects or something, but there's no strict cutoff. Correct. For B, do you have to use an oral lead-in?
No.
Correct. Yeah, when they first did some of the trials and first came out with Cabenuva, this cabotegravir rilpivirine regimen, people did an oral lead-in for a month or so to make sure they didn't have side effects. But in general, it's been so well tolerated that that's no longer required. And often getting your hands on those oral lead-in agents can be tricky, at least in our health department clinic. So many of our patients go straight to the injectable, but there are some cases where you may consider the oral lead-in, and you certainly can do it if you want to. What about C? The injections are clinic administered as gluteal injections.
True.
Yes.
Yeah, that's true. Yeah, patients, this is an important point if you have someone interested. It's given, the first doses are given a month apart, and then it's every 2 months, but they have to be clinic administered. You can't, patients can't go home and do this themselves. So when considering if someone's a good candidate for this, they have to be able and willing to come to the clinic every 2 months, which is more often than most of our patients come by a lot. And then we already know C is correct, but what's wrong with D? Oh, basically everything I just said. Okay. I think we went over that one. And it's 2 gluteal injections, one of cabotegravir and one of rilpivirine. So we've covered most of this, but the key criteria for switching to Cabenuva, per guidelines, people should be virally suppressed for 3 to 6 months before switching to this long-acting 2-agent regimen. I will say there are some small case studies where people have been trying to use it in people who are not virally suppressed, but those people who are really, really struggle with adhering to pills where you're never going to get them on pills. So some people have tried this when it's the only option. That is not technically recommended. They also should not have evidence of or suspected resistance to cabotegravir or rilpivirine. So if you have someone who's interested in switching to the injectable, I'm going to be asking you for their full HIV treatment history. Which pills have they been on? Why did they switch? If they were ever on a pill with an NNRTI, which is rilpivirine's class, why did they switch? Was it for side effects? Was it because they were failing? Because if there's any hint of failure related to especially rilpivirine, I'm probably not going to love this for them. We'll also check any old genotypes they have. And as I said, they have to be able to attend. I didn't put it there, but if they have hepatitis B, it's in the bottom section. If you have hepatitis B, this regimen does not cover hepatitis B. So while this can treat their HIV, they're still going to need daily oral medicines for their hepatitis B treatment. Rilpivirine, when given orally, can interact with PPIs due to absorption, but that's not a problem when it's injected because it's no longer going through that oral route. So that's long-acting Cabenuva. So in summary, we use this case-based approach today to cover some key topics in building your foundation of knowledge for antiretroviral therapy. So we talked about the initial recommended regimens for people with new HIV who either did or did not have prior cabotegravir for PrEP. We talked about management of elite controllers. And then we discussed some common scenarios that we see pretty regularly in HIV clinic, including adverse effects, namely weight gain, hepatitis B co-infection, renal impairments and dose adjustments, drug-drug interactions, and then potential switches to Cabenuva injectable ART. So that's all I've got for today. If people have questions, I'm happy to address them, or if any of the attending faculty on have additional comments, please go ahead.